All right, well, welcome everyone. Thank you for joining us for our webinar on severe maternal morbidity and specifically identifying quality improvement opportunities. So we'll talk through some SMM updates nationally, identifying drivers of SMM at your hospital, the new risk-adjusted version of the SMM rate, and then walk through guidance on how to review your SMM cases. This webinar will be hosted by Dr. Elliott Main, the medical director for CMQCC, and I'm Emily McCormick, one of the program managers at CMQCC's Maternal Data Center. A few quick housekeeping notes. So everyone is muted upon joining. We are recording this webinar and it will be shared in the MDC support section in a few days. The slide deck is already posted if you would like to follow along with us. Our Associate Director, Ann Castles, is manning the Q&A function. So if you have questions, please feel free to utilize that throughout the presentation, and she can answer questions throughout, and then we'll leave time for questions at the end. And then we are offering CEUs for those of you that are joining us in real time. You will need to fill out the evaluation survey that will be sent out tomorrow in order to get your CEU certificate. So please watch out for that coming tomorrow. And with that, I will pass it on to Dr. Main.
Thank you, Emily. First, I'd like to acknowledge that this has really been the work of many people at CMQCC, not only our data center staff and our data center support team at Critical Junction, but also researchers that I collaborate with both at Stanford and, as you'll hear, around California, Oregon, and Washington State. So let me start off by saying, what is severe maternal morbidity? It reflects unanticipated outcomes of the labor and delivery process that results in significant short or long-term consequences to a woman's health. In our current version, we're focusing on labor and delivery, not on postpartum or earlier pregnancy admissions. So this is a narrower view of SMM, which reflects where the national bodies are going. Oftentimes, SMM requires transfer to intensive care or a higher level of care. But what we're going to be focusing on is the ability to learn from SMM cases and in how you review to determine whether the complication could have been prevented and whether the process needs to, our processes of care need to be amended to avoid future cases of severe maternal morbidity. Next slide. So a little bit background on this, on the CDC measure, which has become the standard for use around the United States. It's comprised of 21 indicator groups of major complications. So these are diagnoses and procedure codes like kidney failure, pulmonary edema, transfusions. So the typical rate of SMM is about 1.5% to 2% currently in California and in the US. What's been a finding of the last decade is the continuing rise of the rate of transfusions, so they now comprise more than half the cases of severe maternal morbidity. So now we actually think of it in terms of two measures, total SMM and SMM excluding transfusion codes. Next slide. What we're looking at here is the rise in SMM in California, which parallels the rise in the US as a whole. And you look going back all the way to 1997, the severe maternal morbidity overall rate was 67 per 10,000 or 0.6%, and it's now at 174 or 1.7%. In 2014, it's actually more like 1.9 to 2.0% now in 2020. 64% increase, and also particularly since 2008, a rise in excluding transfusion-only cases, which often represent medical conditions, but we'll describe that, what drives that in a little bit more detail. Next slide. So what's been going up? And these are the major indicator categories. Blood transfusions is the biggest one by far, and it's gone up 400%. In this is US data now from ARC. Hysterectomy has gone up 55%. Being on a ventilator has gone up almost 100% in this time period. DIC has gone up 20% increase from 6 to 7.2. ARDS, acute renal failure also have had serious rises. Sepsis, and actually in most recent years, it's gone up even further in recent data that I've been looking at. Cardiac arrest, so forth. All these have gone up in this time period, but the ones that have the biggest impact are at the top, which is blood transfusions, hysterectomies, and ventilator and DIC. Next slide. This has become a big deal nationally. It's been used extensively in research, publications, and QI projects around in California, in CMQCC, in Washington, Oregon, but elsewhere around the country as well. It's become a Title V national performance measure. So our public health colleagues are very aware of this. AHRQ is now contracted to release state rates on an annual basis, and we're going to talk in a moment about some of the activities there. CMS, which brings us Medicaid, is proposing its use as a hospital level and a plan level Medicaid performance measure. The Joint Commission is developing an electronic version as PC07 as part of the core measure set for all hospitals in the country. Next slide. So there are two working groups working on these areas right now. The first involves the CDC, AHRQ, and HRSA, and we're involved with AIM as consultants on this. As I mentioned, AHRQ is now a contract to calculate SMM. And they're going to do it stratified by race, ethnicity, age, and payer, like they do currently for a number of the AHRQ measures. But they're going to focus on non-transfusion SMM. And this is because some hospitals in some states are not coding transfusion very well, making that unstable measure to look at on a national basis. Total SMM will still be useful, and we plan on continuing doing this, particularly and perhaps focused on hospitals that have adequate transfusion data. But there are also some code revisions that this group is looking at, and these are almost done, and we hope to release them in the next month. Sure, some tweaks in SMM and some tweaks in the change to ICD-10 and the new codes that come out each and every year. Next slide. The second working group is comprised of the Joint Commission, CMS, their Medicaid division, as well as the Yale Core Center, which is a center that's focused on developing Medicare measures for CMS. And they're all working on adjustment for case mix. If you're going to use SMM, as we've talked about before, if you're going to use SMM to compare hospitals, you have to take into account case mix, because that varies dramatically among hospitals in our states. And this is the process that's underway to develop that. This will be an electronic quality measure. PC07 for the Joint Commission, and Medicaid is probably going to build it into their payment structure like they do the other ECQMs for Medicare. There's a strong interest here on excluding indicators that are present on admission, which makes sense. You know, if a patient already is coming with major complications and those 21 indicators, you don't want to be held responsible as a hospital. Now, as a health system, that may be a different matter. As a health system or as a population level, those are still important to keep those in mind. I would say that the Joint Commission measure still is to be having to do it as an electronic measure, includes things like SNOMED and feeds from electronic health records, as well as IC10 codes. Next slide. So we're going to talk for the next 10 minutes about the two outstanding issues for using SMM. One is the case morbidity, case mix, adjusting for comorbidities that strongly affect SMM. How can we risk adjust SMM now and using currently available ICD-10 codes? Secondly is the recognition that SMM represents complications, not the conditions that are the causes or drivers of the complications. How can we identify those? So if you have a set of complications, what's really driving that? And that's where you really want to spend your quality improvement time, is on what are the causes of the complications. Next slide. So first of all, we spent a lot of time working on a comorbidity system for predicting severe maternal morbidity to use as a risk adjustment model. We built on an earlier model by Brian Bateman from Harvard, who did this about a decade ago with a different definition of severe maternal morbidity and a very limited set of comorbidities. So we expanded it to 27 categories of comorbidities, including prior section, maternal age, obesity, and evaluated for their independent, this is really important, independent prediction of SMM and SMM with child transfusion. We did this in a way so they could be done in an additive way to each other, because many people will have multiple comorbidities, and you want to be able to take those into account appropriately. So we looked at this in a California data set. We split it into developmental and a validation set, which is exactly what you're supposed to do as you pick out your risk adjustment measures, and confirmed it using a separate national data set for births. This was just published in September in the Green Journal, and it actually had an editorial that went with it by actually Brian Bateman, who developed the earlier one that we significantly improved on, as you will see. And he said we got it right, and that was very encouraging to see. Next slide. So these are the type of codes or the types of conditions that are in the, were considered for the index for risk adjustment. So obviously things like chronic hypertension, diabetes, placenta previa, preeclampsia are all important comorbidities for risk adjustment. We added on in the purple a lot more codes and interest for asthma, for bleeding disorders, for renal disease, advanced maternal age. We added substance use disorder and added on to that. And then added on pre-existing anemia and things like economic and housing instability and mental health disorders, as well as placental abruption and placenta accreta. Next slide.
Dr. Main, before you go, would you mind speaking just a tad louder? Somebody
Sure.
noted it's a little garbled. Thank you.
Okay. So this gives you a sense of what the prevalence of the comorbidities are. They range in frequency from advanced maternal age, 22% of the population in California, down to HIV/AIDS, which is 1 in 10,000 patients in California. Prior section is about 18%. Pre-existing anemia is pretty common. And this is going to be an important issue that we remember for this project and for others going forward. But this gives you a sense of how often some of these are. Next slide. So as part of the process, we developed a relative risk for each individual risk factor and a point scoring system which goes into the process for establishing the risk for this particular patient. For example, then, placenta accreta syndrome spectrum has a 30-fold risk of severe maternal morbidity over the risk factor with the least risk, which will be 1.01, which is gestational diabetes, doesn't give you much additional risk. But you see pulmonary hypertension, which is actually one of the strongest risks for maternal mortality, is 17-fold higher risk for severe maternal morbidity, and down the list. Previa is almost 5 times the risk. Pre-existing anemia gives you 3.5-fold higher risk. So that's, again, cropping up. Prematurity, 2.8 times the risk of severe maternal morbidity. Next slide. Going down the list, we see preeclampsia severe features, twice the risk. Severe asthma is also a higher risk complication. Going down, major mental health disorders, 1.5-fold. And advanced maternal age and prior cesarean birth are modest risk factors. And what was sort of interesting is BMI of greater than 40, so 1.4, which is lower than you might expect. And what that indicates is that the biggest risk for high BMIs, obesity, or maternal age is actually the complications that you get that are often comorbid with it. Like if you're obese, you are more apt to have hypertension and diabetes, and you add those all up, and all of a sudden you're at a pretty high risk. But if you're obese and you don't have diabetes or hypertension or any of these others, your risk factor is still there, but it's significantly lower than if you have the other complications. Next slide. So description is actually on our website. Details for the comorbidity index I showed, so you don't have to go to the Green Journal. It's here and described. This is the place we'll be updating as we make tweaks to the very complicated algorithm for establishing adjustments. Next slide. We've run this on some of our hospitals in California, and I want to give you a taste of how it works. Here is all the hospitals in California divided up by their hospital level. Level is established by their NICU level, which roughly correlates to what we expect to occur with the maternal levels of care, but those haven't been established yet for California. So we have critical access hospitals, no really change as an aggregate when you risk adjust. Nursery level ones, not critical access, actually risk adjust a little higher. So the rate of SMM after adjustment is higher for those hospitals, suggesting there may be some patients there that might have benefited from delivering elsewhere. Level 2, level 3, level 4 are about the same. The next slide shows you where it gets really interesting. First is looking at the highest of the high acuity facilities in California, which would be the 7 main campus university hospitals. They do have observed rates of severe maternal morbidity that are quite a bit higher, averaging 3.5%. Remember, the observed rate overall in California is 1.7%. You can see these are 3, 4, 5. There's one that's 1, 2. When you risk adjust the university hospitals for their patient population, they actually adjust down to state average, 1.5%, state average 1.7%. And that's really kind of interesting how that works. The other population that people worry about being disadvantaged by their patient population are the large county hospitals in California. Next slide shows those 7 large county hospitals. These would include places like LA County, San Francisco General, Santa Clara Valley, and the like. And they actually have also very high rates of severe maternal morbidity unadjusted. And the observed rate is averaging 3.9%. When you adjust just simply for their comorbid events, comorbidities, that includes mental health and substance use, as well as other medical conditions, they also risk adjust down to a pretty average rate compared to the state as a whole, 1.8% versus 1.7%. Next slide. We're looking to see about risk adjustment by race, but there are additional considerations, and so we're cautious about this. There have been a number of articles out recently about using race and risk adjustment, and so we have to be very cautious in our interpretation and framing of results. We don't want to be blaming the patient. We don't want to be dismissal of the role of social determinants and structural racism. And we don't want to reduce provider responsibility for initiation of quality of care and overlook intervention opportunities. We know that SMM, severe maternal morbidity risk factors, are grossly categorized within our risk adjustment model, and they have gradation. You know, chronic hypertension can be, history of or maybe one medicine, or it could be on 3 medications. Very difficult to control versus easy to control. Different populations may have varying case to morbidity ratios. So we know there's very different case to mortality ratios, i.e. if you have hypertension, what is your chance of having a death varies by among different populations. The same can be true, and we're investigating this, about if you have hypertension, does it vary about what your risk of severe maternal morbidity is among different racial and ethnic groups. Next slide. So stay tuned for that. I'm going to switch gears and talk for the next couple of minutes on severe maternal morbidity underlying causes. As we said at the outset, severe maternal morbidity is a list of 21 major complications, but not the causes. What we want for QI is to identify the underlying cause or the driver of the complication. For example, pulmonary edema, which is an SMM, is rarely a respiratory disorder, a primary respiratory disorder. The underlying causes are typically preeclampsia, severe hemorrhage, cardiac disease, sepsis. So you can't go into this thinking, okay, let's attack pulmonary edema in general, but you really have to look at what were the underlying causes in these cases. So was it preeclampsia or was it hemorrhage? Next slide shows that a little bit more detail about what we mean by underlying causes. So we've divided them into about 11 categories, which are defined in this way. And we worked with a review group up and down the West Coast to help hone this. We're actually on our version 15 of the algorithm as we've gotten feedback and feedback and feedback. So obstetric hemorrhage includes atony, hematomas, or lacerations of any type, postoperative bleeding, and bleeding from myomas at C-sections. Placental hemorrhage, though, is previacrete abruption and retained placenta. Infection includes sepsis, endometritis, pyelonephritis, pneumonia in choreo when it leads to hemorrhage. So choreo alone, without sepsis, would not be in the infection category. Preeclampsia includes your typical features that you'd want to risk adjust for. Preeclampsia with severe feature, eclampsia, HELP syndrome. And we also looked at where this hemorrhage was a result of these. And actually women with, just like women with choreo have a very high rate of hemorrhage, women with preeclampsia have a very high rate of hemorrhage as well. Anemia on admission. We were able to identify this from ICD-10 codes. These are all driven by ICD-10 codes, by the way. What we did was to look at the SMM and then all the additional ICD-10 codes the patient had to be able to identify what was underlying. Next slide. The other categories include hematological conditions, other medical conditions, other obstetric conditions, as you see here, and cardiovascular conditions. These are all much less common, as you'll see in a moment. Venous thromboembolism can be a underlying cause that is straightforward. Next slide. So we have the 21 conditions and then the underlying causes. And so we developed the algorithm and have refined it and refined it by working with 13 hospitals in our 3 states, and have reviewed more than 600 cases of severe maternal morbidity with case review, chart review, and then looked at 100,000 cases of severe maternal morbidity in our very large California data sets. And there's a couple of things that are clear. One is, next slide, if you look at DIC, it can be caused by many different underlying causes or underlying conditions. Atony, placental hemorrhage, infection causes DIC. Preeclampsia does, of course, and ITP and other underlying medical conditions. Likewise, next slide, when you look at transfusion, there are many different underlying reasons for transfusion. In fact, almost the entire list is possible cause of. So you don't want to look just at transfusion, you want to look at your care of women with, say, preeclampsia, or your care of women with anemia on admission. You know, what's driving why they have anemia. Next slide. So the underlying cause assignment is by algorithm, and here's some examples. If you have a stroke, and if you also have preeclampsia with severe features, we categorize it as preeclampsia. If you have a hysterectomy, and if it's in a previa of accreta, it goes to placenta hemorrhage. If it's uterine rupture, it goes to other OB conditions. If it's cervical cancer, it goes to other medical conditions. And there are some, but actually pretty small number of those. Likewise, if it's transfusion, we have an algorithm that walks you through how it's ending up in placental hemorrhage, obstetric hemorrhage, preeclampsia, but some in infection and some again in obstetric hemorrhage further down, or anemia on admission. Simplified. Next slide. These are some of what we found. So we showed you earlier the proportion of cases that were SMM. This is the proportion of cases that have the underlying cause for SMM. And what you see at the outset, and this is based on ICD-10 data from about 24,000 cases of SMM in California, is that about half of all SMM is related to hemorrhage. Should not be a surprise for those in the audience. So between obstetric and placenta hemorrhage, that's 50%. Infection and choreo and preeclampsia account for another 30%. So those are the next two big drivers. But actually, it's interesting. We saw this again and again in feedback from our hospitals that anemia on admission was a real important one. And we're about to embark on an anemia in prenatal care for women with anemia collaborative. So stay tuned, that's coming up next year. And then we have a mix of other conditions that are relatively small proportions, 2 or 3% from things like ITP or medical conditions or cardiovascular conditions. The big ones, though, are clearly hemorrhage, infection, preeclampsia, and anemia. Next slide. So what we want to do, and this is going to be a lead into how we're going to display these and help you understand these, is that we're going to be displaying in the data center both a tie-in between the complication going backwards to the underlying cause, what patient conditions likely led to the severe maternal morbidity complication developing, and then giving you the ability to put these together in a case review to look and examine for quality improvement issues. And we're going to give you some typical questions to be asked. These are underlined by what we've got in the data center from diagnosis and procedure codes, and will be supplemented by data on chart review. Next slide. I'm going to turn this now over to Emily, who's going to take us through the data center. Thanks, Emily.
Great, thank you, Dr. Mean. And just as a reminder, please feel free to put questions in the Q&A box, and Anne will answer them as we go through, or if we have time at the end, we'll try to answer some questions as well. So we're going to dive into the new SMM tools in the Maternal Data Center. So we're going to talk through how to monitor, interpret, and address your SMM rate using the tools in the MDC. So this is just an overview of the new SMM enhancements in the Maternal Data Center. So we've updated the patient drill down screens. As Dr. Main mentioned, we've added a new risk-adjusted version of SMM available in the Maternal Data Center. We've updated and expanded the measure analysis section to now include the underlying cause. We've updated the SMM case review metric in the Maternal Data Center. And then we've added a brand new case review measure analysis to help you take those improvement opportunities that you're identifying and break them down to potentially identify some system issues that can be addressed. We've updated the SMM CSV downloads to incorporate all of these new features. And then we have a new SMM case review PDF that will be rolling out in stages. Some of you who have logged into the Maternal Data Center this morning may have seen some of these updates as they were rolled out last night. So they are available for you to explore in the Maternal Data Center. So just as a reminder, this is what your severe maternal morbidity metric looks like in the Maternal Data Center. This in particular has not changed. You still have your overall metric and your SMM excluding transfusions. And then you can drill down to the patient level by either clicking on the table below the graph or on a point on the graph. So if I click in there, it's going to take us to these new updated SMM drill down screens. So those of you that are familiar with these screens, you'll see some new changes. We have a new SMM complications header. This used to be called SMM category. We now show the SMM underlying cause, as well as the estimated risk of SMM. And this ties back to what Dr. Main was explaining at the beginning of the presentation. So let's go through what each of these mean. If you click on the little green question mark here, you will see the definition for each of these. So the SMM complication identifies the specific maternal complication that constitutes the SMM per the CDC's measure specifications. A patient can have multiple different complications. So for example, this patient has both DIC and transfusion. So all of their complications will be listed here. Next, we'll show the SMM underlying cause as assigned by the algorithm that Dr. Main reviewed. In contrast to the SMM complications, while a patient can have several complications, they will only have one underlying cause. So that's the one that you will see here. If you disagree with what the algorithm says, I'll show you a way to fix it, but this is a nice way to figure out what is driving your SMM rate overall. And then last, we have the estimated risk percent of SMM. So this is reflecting each patient's likelihood of developing a severe maternal morbidity given their underlying complications. So it ranges from 0 to 100%, and it's using those ICD-10 codes that are submitted to the Maternal Data Center. You can use this how you like. You may choose to focus on your low-risk patients to question why someone who is seemingly low acuity developed an SMM, or maybe you focus on your high-risk patients who you may not see often at your hospital, but maybe you need to develop new processes to help address some of those high acuity patients. Completely up to you, but this information is there for you to use as a quality improvement review tool. As a reminder, on these screens, you can always click the header to sort your columns. So if you want to sort your patients by estimated risk or sort them by underlying cause, that's always available to you. I mentioned that you can edit the underlying cause if you would like to. So say for this patient, I didn't agree that it was a other medical condition. I thought it was actually just an obstetric hemorrhage that was the underlying cause of the DIC and transfusion. I can go ahead and click on this green edit pencil. It will take me to the patient editing screen, and you'll see a drop-down menu here where you can select the underlying cause that you want to attribute for this patient. Once you save that, then it will now show up as highlighted yellow to reflect that it has been changed. And if you hover over it, you'll see what the original calculated underlying cause was based on the algorithm, but it will reflect what you actually assign. If you have feedback on this underlying cause algorithm, please let us know. We'll be watching to see as things are edited, but if you have specific questions, please don't hesitate to reach out to us. Next, like I mentioned, we have our new risk-adjusted version of SMM. This is available on the hospital clinical measures list, or you can always use this toggle at the top to toggle between the measures. And we really encourage you to use this risk-adjusted version for your peer comparisons. So that way you can take into account the comorbidities that your patients are coming in with. So this is available, and it's in addition to, not in lieu of, the regular SMM metric. Next, we've updated the SMM measure analysis section. So from the trend screen, you'll see this measure analysis link on the left navigational bar. If you click in here, you will see your SMM cases organized by category. We've condensed those 21 SMM indicators or complications into categories. You can hover over each of these categories to see what indicators or complications are included in each category. And then if you click into one of these, you will see a trend screen or a trend graph for that specific category. So say you wanted to see the trend of your SMM sepsis cases over time, you could click into this header. If you just want to see the list of patients, you can click into the number here. If you continue to scroll down that SMM measure analysis screen, you will now see a breakdown by SMM underlying cause. Again, if you hover over the cause itself, you'll see examples of what's included in each one. And then if you click on the header, you will be taken to a trend screen for each. So the goal is really to help focus your QI efforts to see what is driving your SMM rate. So maybe you want to see the trend of anemia on admission over time. One distinction here that I want to call out, like I mentioned, a patient can have several different SMM complications. So they may show up in several different categories on the top table in the measure analysis section, but they can only have one underlying cause. So they will only be reflected in one underlying cause bucket at the bottom of the measure analysis section. Next, we have revamped the SMM cases reviewed section in the Maternal Data Center. Some of you were actively using this, some weren't. There are two ways to access this tool. It was always linked at the top of the SMM trend screen, or from the data entry status screen, there was an SMM case reviews row on that table, and you could access the case review by clicking the action needed for each month. So this is what the old version looked like. We would show you a list of all of your SMM cases. There would be an edit button here, and when you clicked that, this screen would pop up. So we would ask you which issues, if any, may have impacted the SMM. You could mark if the morbidity was present on admission, or if it was referred to committee. Well, I apologize. We got feedback from hospitals that this current form wasn't really working. We wanted to be able to select that a morbidity was present on admission and improvement opportunities, or select improvement opportunities and referred to committee. So we assembled a working group, and I want to extend a hearty appreciation to those that provided feedback on this. And so the changes and updates that you will see are a reflection of that feedback that we got from hospitals. So you will access the SMM case reviews the same way, either from the top of the SMM trend screen or from that row in the data entry status screen. But when you click this edit button, the questions are now different. So the first question asks, would you like to review this case in the Maternal Data Center? You have the option to say no. So if you want to just use this tool to track that it has been reviewed, but you don't necessarily want to identify the specific improvement opportunities, this is a way to do that. So if you select no, it's been reviewed, but I don't want to review it in the Maternal Data Center, it will now say reviewed offline. You can always do a combination if you want to review some in the Maternal Data Center, but then mark no for others, that's fine. Just know that we need you to answer this question one way or another for us to take it to the next step. If you answer yes, I want to review this case in the Maternal Data Center, then these new questions are going to start popping up. So first we ask, was the case reviewed by committee? Was the case debriefed during the hospitalization? Because we acknowledge that a case review and a debrief are different. You can mark if all of the SMM complications were present on admission. And then you can select if any of these improvement opportunities apply, and if not, you can click no opportunities for improvement down here. You can always add comments here, and those will stay with the patient throughout the Maternal Data Center. So the biggest difference here is that these questions are no longer linked, so you can answer them separately. And then we've expanded this list to hopefully be more inclusive of major issues that you run into during the progression of an SMM. So if you respond to all of the case review questions, so you either mark, yes, I want to answer it in the Maternal Data Center and answer those questions, or no, we reviewed it offline. Once all of your cases have been addressed for that month, you will then be able to click View Measure Results at the bottom of that screen, and it will take you to this trend screen. So this way you can start seeing this trend over time of your improvement opportunities. So this stacked bar chart will show you the percentage of cases of SMM that had improvement opportunities, those that didn't have improvement opportunities, and then we'll denote if you had specific cases that you didn't review in the maternal data center. It will say reviewed offline. Again, like with all of our stacked bar charts, you could always click these off and then just see the trend of improvement opportunities over time. So that only gets you so far. It's not necessarily actionable. It's good to see the trend, but we really want to figure out what's going on with these cases. So we built in an SMM case reviews measure analysis section. So again, from the trend screen, you'll now see a measure analysis option on that left navigational bar. And so first, we'll give you a summary of your case reviews for that time period. So we can show you, okay, you had 4 SMM cases during this 4-month period. You reviewed 3 of them in the maternal data center, and of those 3, 1 was reviewed by committee and 1 was debriefed during the hospitalization. You can also filter by underlying cause. And so if you want to look at all of your preeclampsia cases, you can then mark down, I want to filter by preeclampsia underlying cause, and then see how many of those preeclampsia cases were debriefed during the hospitalization, or how many of those hemorrhage cases were debriefed. This may be a useful tool for those of you that are looking to address the debriefing portion of the Joint Commission Perinatal Standards. So just know that this is a way for you to help track those debriefs in the maternal data center for those cases that met SMM criteria. If you continue to scroll down the measure analysis screen, you will next see a table that shows SMM complications based on present on admission status. So this is potentially most helpful for those tertiary care centers or the referral centers that are accepting patients from other facilities that may be a ways down the SMM path already by the time they hit your doors. So this is a good way to focus your case review process. So all of these numbers are hyperlinked, so you could go in and click this and view a list of those patients. And so we're sorting it based on whether the complications were present on admission or not. Please keep in mind that even though someone may have shown up with an SMM, that morbidity may worsen during their hospitalization. So we don't want you to completely write off those cases where it was present on admission, but this is just a new way to organize your cases. Please note that if you mark a case as present on admission, we are not excluding it from your SMM rate, but instead we will provide this sorting for you to help guide your case review process. And lastly, at the bottom of this page, we will sort your improvement opportunities by QI domain. So this way you can see, okay, of all of my cases, in this case, 2 of them had improvement opportunities, and then seeing what's really driving these. So I would say, okay, this is mostly communication issues, and really it's teamwork issues like not following the chain of communication. You can also filter by underlying cause, because we know that sometimes the opportunities for improvement differ between types of case. So for example, you might have more communication issues in your infection and chorio cases, but really a delay in treatment is the root of the issues in the preeclampsia or eclampsia cases. So again, that filter that we showed at the top of the page will apply to this table as well. And then you can click into these numbers in order to view these cases to do a deeper dive. Like I mentioned, we have updated the CSV downloads to incorporate all of these new fields. So you'll start to see the underlying cause category, the estimated risk percent, whether they were reviewed by committee, if they're debriefed, the POA status, and then those improvement opportunities if you've documented them in the maternal data center. If you have not, those columns will be blank. And this download button is available on the patient drill down screens. You'll see this download XLS button. One of the last things that we're very excited about is a new case review PDF. And so we wanted to make sure that there was a standardized way for you to review your SMM cases, as that's ultimately our goal. Whether you're comfortable putting those improvement opportunities into the maternal data center or not, we wanted to provide this guidance. So this first page provides clinical information about the patient, And then the second page kind of guides you through what the discussion would be in a case review setting. So identifying if the complications were present on admission, what issues may have impacted it, what could have been done differently, and then what the action steps are moving forward. So these questions align with the case review metric in the Maternal Data Center. So just know that these are the same. So if you wanted to take this form, fill this out, and then put that information back into the Maternal Data Center, you could do that. So for now, there is a copy of this case review form in the support section. So you can go ahead and download it. It is fillable, so you can put in all of that information. And in the next few months, we are going to be rolling out a pre-filled case review PDF. So you'd be able to go to this chart review screen and download a batch of these PDFs that are pre-filled out with all of the clinical information for your SMM cases for that period. So please watch out for announcements from us about that coming soon. So again, I know that we went over a lot of enhancements. There's a lot of new things for you to play with and explore. Please don't hesitate to ask us questions, but we're very excited for you to start diving in and utilizing these tools for quality improvement. And if you are completely overwhelmed, I want to emphasize that there are 3 places that you can start diving into SMM. So 1, you can start on the trend screen, ask the question, is my trend changing over time? If I change the frequency, do I see a more cohesive trend? Look at SMM without transfusions, use that risk-adjusted measure for peer comparisons. It's a great place to start. Another place is the measure analysis section. So looking at the complication category and then diving into the underlying cause to see what's driving it. And then lastly, the patient drill down screen. So what issues are driving the specific case? And is there anything that could have been done differently to prevent this SMM? And so this is where we really want you to take those case review tools and start applying them to identify the opportunities for improvement. So this slide is up in the Maternal Data Center support section. So if you are completely overwhelmed, this is a great place to start. Lastly, we're going to be adding lots more materials to this SMM section in the support tab, and you can always contact us using this contact button in the MDC. So I'd like to open it up for questions, and if you would kindly moderate for us if there's been any good ones that we can address from the Q&A.
Absolutely. The first couple are going to be for Dr. Main around the risk adjustment algorithm. And the first comes from Kisha at KP San Diego. How do you verify economic and housing instability?
So those were actually ICD-10 codes, and we, that are new. They're in the Z section, and they actually didn't make the final cut because they haven't been used as much as we'd like them to be. There's a big CMS push to code for those so they can be used in the future. So we're keeping an eye on it. That was one of our proposed additions, but when we did the formal algorithm analysis, it didn't make the cut. So stay tuned on that. There are codes to be used though for that.
Next question. There's some strong evidence that childbearing NICU grads themselves have a higher incidence of underlying pulmonary hypertension. Is there any recommendation from ACOG or from CMQCC on including the question of, were you born preterm, especially if we are considering pre-existing conditions?
It's, as our preemies are growing up and having children of their own, there are all kinds of interesting questions to be asked. There is evidence that preemies begat preemies. There's a higher rate of premature birth among people who were preemie themselves. That's where the most data is, but it hasn't yet evolved to being a clear-cut risk factor of its own at this point. So stay tuned on that one.
Okay, next question. Is it known yet if the Joint Commission's new Ecqm PC07 will be using SMM with or without transfusions, or if they're going to be incorporating risk adjustment?
So it is going to be a quote. It will be used risk adjustment, and we're consulting with them on that. It will also use present on admission for SMM categories, i.e. if it's present on admission, it would be excluded from the measure. The other details are still being worked out, and it's still probably about a year to go. What was the other part of the question that I skipped over, Ann?
Let me go back to it, sorry.
On this part of it.
I apologize, I went ahead and clicked answer.
No matter, let's go on to the next one.
Okay. One more for you right now. Should COVID-19 be considered an infection underlying cause or just noted as a medical history condition?
There are new codes as of April for COVID-19 infection. The issue is less that there's you have a positive test for COVID-19. It's more whether you had actual pulmonary or other complications for COVID-19. So those complications would be coded as comorbidities here, rather than just being a test positive.
And going back to the original question about the new Joint Commission PCO7, the other part of it was, will they be using SMM with or without transfusions?
Oh, it's probably, that hasn't been decided yet. It's probably they'll be going with SMM without transfusions, as will ARC. That's what I was saying, though, that the transfusion still is an important thing to follow, and there are some drivers for that. But SMM without transfusion is probably going to be the national performance measure.
Great. Okay, it looks like next set of questions are related to the Maternal Data Center functionality. Emily, would you mind going back over where to find the SMM case review PDFs? And I know there are a couple of different places. Maybe we can point them out, both of those places to folks.
Absolutely. So right now we have a blank version of the SMM case review PDF available in the support section. So if you click on support in the top black bar of the Maternal Data Center, and then under the user guides tab, you'll see a severe maternal morbidity header. Then that case review PDF is available there. We, in the next few months, are working towards making a pre-filled version of the case review PDF worksheet, which will have your SMM patients for that period. Their clinical information will be available on this front page. So this will pretty much all be filled out by the Maternal Data Center. We're just working out some last minute tweaks on that. And that you can download from this case review PDF button that will be in the chart review section of the SMM case reviews. And once we roll this out, we'll provide lots of guidance on where you can find it. But that's coming here in the next few months.
I'd just like to add that all these features were designed to be applicable for all levels of hospitals. We really wanted to be able to provide guidance for small hospitals who may not have done a lot of this before, careful in-depth reviews, as well as the ability for larger hospitals that have large number of cases to be able to track and trend. So I think there's something in here for everyone.
Can you also review, Emily, where to find the editing pencil on the patient drill down for SMM?
Absolutely. Did a lot of slides. So on the drill down screen, there's two places where you can edit a case. First, there is this green edit pencil here, or if you click into this patient's record, then you'll see an edit button in the top right-hand corner. So you can edit both ways. Please note that if you are only a read-only user in the Maternal Data Center, you may not have this functionality. So if you have any questions about that, then please reach out to us, because we'd love to work with you to make sure that you have the access that you need based on what your hospital administrators deem necessary. But that is where you can edit the case, both from this green pencil or clicking in to the case here. So if for some reason the green pencil is not showing up, sometimes we find on specific browsers it doesn't show up. You can always click into the case here and then click the edit button in the top right-hand corner.
What you see on the screen here for editing underlying cause is the pull-down menu that has all the algorithm, well, most of the algorithm for why it was assigned to that category. And so that you can use for teaching purposes about why it was in that category.
Okay, it looks like someone might be having trouble seeing the editing pencil, but hopefully the person who's having the issue can go through the MRN and then go through the case screen, but we will follow up separately with you, Julie.
Absolutely.
Okay, a couple people have asked about where to find the slides. I'll go ahead, if you are in the Maternal Data Center, top black bar, go to the support section. It's the last link in the top black bar. Then once you're there, there are several tabs. The second tab is for trainings and webinars. And then you go to the webinar subheader and you will find it. It's the first in the list under the webinar subheader. So that is already there, so you can download it immediately. Okay, there's a comment for Dr. Main. Too bad we can't do some kind of retrospective study looking at SMM and those that have pulmonary hypertension as a complication. Were these women born preterm? Just to follow up to my first question. So not a question, just a comment. Thank you, Dr. Main. Okay, and then another.
Just to add that, patients in the data center are de-identified. So we wouldn't be able to do that. We'd have to work with every individual hospital to identify those. But anyway, it's of interest.
Okay. And another comment, good work CMQCC. This is going to help our survey readiness when the Joint Commission perinatal standards go live. Okay, I think this is the end of all of our questions.
I will point out one thing for those of you that were using the historical version of the case review function. So that data is preserved in the Maternal Data Center. So we didn't just wipe it out with the new updates. Just know that you can access it by clicking into a previous month and then clicking View Measure Results, or on you'll see a See Measure Detail or See More Details link here at the top of the new trend screen. If you click that, you'll see a link to your old data. So we didn't get rid of it, but we just know that the questions are different. And so we didn't necessarily want to compare because it is a little different. So just know that data is there, but it's just hidden a little bit, but it is still available for you.
And then there's a new question. Will the webinar be available through the CMQCC and not just through the Maternal Data Center?
I was going to ask that question too. We should be able to post it on the website directly with our other webinars. So.
Yes, but yeah, it'll be in our YouTube channel is where the ultimate link goes to. And then you'll be able to link to our YouTube channel from both the Maternal Data Center section. We will make sure that it's also up through cmqcc.org. Okay, I am not seeing any other questions, and we're at the top of the hour. Very well timed. Thank you, Dr. Main. Thank you, Emily. And of course, we at CMQCC and the Maternal Data Center are happy to help you as you have questions, as you start to use these new features in the Maternal Data Center. Just contact us through the support section and click Contact MDC. Thank you, everyone, and have a wonderful afternoon.
Take care, everyone.
One thing I'll highlight, please, RNs, if you want to use this as a CEU, make sure that you fill out the evaluation survey. And then we have another upcoming CEU opportunity with the San Francisco Bay Area A1 chapter. So Dr. Main and two of our clinical leads will be speaking on an overview of CMQCC. So please look out for that.